So I'm going to end there. We're going to take questions later at the panel. So I'm going to end now and move on to our next speaker. And I thank you for listening. So it is a pleasure to introduce, except it's not Phil. It would be a pleasure to introduce Phil if he were the next speaker, and it will be a pleasure to introduce him. But it's also a pleasure to introduce Luis Felipe Flores-Suarez. Luis Felipe has been doing vasculitis research for longer than he'd like to admit. He has been doing it unusual among our group. He's been doing it on multiple continents. He has studied in Europe. He has studied England. He is the leading investigator in Mexico and clinician for seeing patients with vasculitis. He's involved in clinical trials and in translational and epidemiologic research. He is well respected throughout the world and really knows about all these types of vasculitis and has generously come up from Mexico, where he will also be leading our Spanish language session, a first for the Vasculitis Foundation, tomorrow. So Luis Felipe is going to talk to us about Churg Strauss syndrome, microscopic polyangitis, and Wegener's granulomatosis. He's going to do it in exactly 20 minutes. Thank you, Luis Felipe.
Well, thank you very much, Dr. Merkel. I didn't see the good-looking ones in your last slide, but anyway. I'm extremely honored to be here, and I want to thank the organizers and all those involved in this symposium. And just as Dr. Merkel said, I come from Mexico City, and I've been asked to talk and give an overview of these three diseases which constitute what we call ANCA-associated vasculitis. And I'll start by saying, although these diseases grouped are not as common as, for example, giant cell arteritis, that we will listen later on from Dr. Weyland, since the introduction of ANCA to the diagnostic armamentarium of these diseases, they have been seen much more frequently than before, or diagnosed more frequently. And this slide just depicts some of the epidemiological data from different countries regarding the prevalence, that is, how often does a disease present in a defined time in a certain population. And overall, we can say in a general sense that, for example, Wegener's granulomatosis seems to be much more prevalent or frequent in countries which lay north, in a northern latitude, for example, in the Great Britain or in Germany or in Norway, as compared, for example, to certain areas of the USA, and not to say or mention other southern latitude countries. In contrast, microscopic polyangitis seems to have a less frequency in those northern countries compared to the southern ones. However, we have interesting figures showing, for example, that in Australia and also in New Zealand, although we might think from what I just said before, these diseases are very, very uncommon, well, they have reported the highest prevalence already for all the studies that deal with this thing. For example, also, there is an interesting difference concerning how often these diseases are in the Far East. For example, we know now that almost all patients in China and Japan bear or have microscopic polyangitis, and indeed over 90% of these patients with ANCA-associated vasculitis have antibodies to a protein called myeloperoxidase. Nevertheless, these diseases tend to be more, or seem to be much more widespread in all ethnic groups, as opposed, for example, to what I just mentioned, giant cell arteritis, which is much more common in Caucasians. In contrast, we see ANCA-associated vasculitis, and for that I mean these three diseases, in blacks, in Asians, in Latin Americans, in so-called Hispanics, almost in the same way as in different countries, as opposed to the ones I just mentioned before. In the next part of my talk, I will mention what I have called convergence and divergence into these diseases. And the first convergence is that for these diseases, there is an accuser, and those are those antibodies called ANCA. And they are grouped together here. And just as Dr. Merkel told us before, they affect every vessel, nonetheless of the size. I mean, no matter the size of this vessel. They can go and injure very small capillaries and also arterioles or small venules. In contrast to what happens, for example, with other diseases which affect main branches of the organs or the aorta as well. And I will summarize as an introduction to the rest of my talk some features of each of these diseases. For example, vaginal granulomatosis, or as it may be called in the future, ANCA-associated vasculitis with granulomatosis, mostly involves ear, throat, and eyes very frequently, and can present in the lung as nodules, what is the clinical or the radiological counterpart of what in pathology is called granulomas. They associate mostly with antibodies against a protein called proteinase 3, which is a molecule that is contained in small sacs called granules and neutrophils, which is one of the 5 types of white blood vessels that circulate in our blood. Then microscopic polyangitis has similar features to vagus, but it involves more often kidneys and peripheral nerves. And very seldom, although we can say almost inexistent, is the presence of those granulomas. And lung disease in this pathology usually is in the form of alveolar hemorrhage, or what Dr. Merkel said before, coughing with, for example, blood tingle sputum. The C-ANCA pattern is very rare, and most of the antibodies found here react to another molecule in those granules called myeloperoxidase. Churg Strauss syndrome, or eosinophilic allergic granulomatous, a very complex name, has 3 phases. It can be divided into a first one called allergic, in where allergic rhinitis is present, and asthma as well. And this phase may precede the others for up to 10 years or even more. Then it gets into another phase called eosinophilic, with abnormally high levels of another white blood cell in the blood called eosinophils. And finally, in the vasculitic phase, a full-blown disease where basal inflammation is present and other organs then get affected, constitutes the final stage for this disease. Much less ANCA patients, positive patients are seen in this disease compared to vaginous granulomatosis and microscopic polyangitis. And I have mentioned many times ANCA, and these are the most frequent or the 2 patterns that are recognized by a technique called indirect immunofluorescence, in where these small granules in the neutrophils give a very bright, under this microscope, this fluorescent microscope, brightness. If they distribute in all, for example, not the central part, but in the periphery, let's say, of the cell, we call it a cytoplasmic pattern. And if they go and clump in the center of the cell, covering the nucleus, or defining very well the nucleus of these cells, we call them perinuclear pattern. However, this technique is not as exact as if we, for example, take all these sacs and purify all the components and the proteins that are contained in this. These small sacs contain, besides these 2 proteins, proteinase 3 and myeloperoxidase, many other substances. So we need to really find out if this reaction is specific, and for that we use another technique called ELISA, or enzyme-linked immunosorbent assay, and those are that's the acrostic for, ELISA is the acrostic for that very, very big name, in where we take all these proteins and we fix them or bind them to a plate. And thereafter, we can incubate the sera of the patients and exactly detect if the antibodies present in the serum of these patients react to either proteinase 3 or myeloperoxidase. So we can then be very precise in which antibodies are being detected or are circulating in some of the patients with these diseases. And in this slide, I summarize how many positive patients with vaginous microscopic polyangitis or Churg Strauss syndrome have antibodies to these diseases. And it depends on many factors: the stage of the disease, how widespread it is, if it has been treated or not, the lab tests used to this purpose or for this purpose. And you can see, for example, that most of patients with Wegeners have antibodies to proteinase 3, that patients with microscopic polyangitis mostly have antibodies to myeloperoxidase, and Churg Strauss syndrome rarely associates with antibodies to proteinase 3. The majority are myeloperoxidase positive. However, some patients also do not have these antibodies detectable, in spite they have biopsy-proven disease. So we need to be very careful, especially if indirect immunofluorescence is used as the only test, because other conditions can also give a positive ANCA result by this technique. So there are many, many other diseases, and I want to point out some of them. For example, infections. Oh, what happened? Infections, or just as Dr. Merkel said, some other drugs can give rise to these antibodies. So we really need to be very careful in interpreting an immunofluorescence ANCA test and bringing into the scope of each condition, each individual, and which symptoms these patients have. So for the other part of the talk, I will mention some other convergences and divergences. And these figures relate to which symptoms are present in these diseases. Taking into consideration, they come from different units, for example, from different populations, from nephrology departments, from rheumatology departments, and that explains this intervals you will be seeing there. For example, in the upper airways, we find out that Wegeners granulomatosis and Churg Strauss syndrome have these features more commonly than microscopic polyangitis.